So on the call today, we're going to be talking about fall risk reduction from the perspective of patients and families. But first, we have a couple housekeeping issues to go through. First of all, again, this is Anne, and I have Dawn and Vicki are here as well. I will be sending out quarterly data reports to all the hospitals in the collaborative that reported at least one fall into the system in 2019. So you should be expecting that within the next week, and it will either come from me or it'll come from Janae Murray. We wanted to also remind you that reporting of all falls is encouraged. In the beginning, we were just really focused on those acute falls, but we're really looking to see what we can learn about the outpatient ER, long-term care, other types of falls. And as we're still kind of talking about the reporting system, if you have any issues with the reporting system, if you need to have users added, if there's been some turnover, if you haven't used the system in a while, you can't get in, send me an email and I can get you hooked up, and we can contact our administrator and take care of that right away. And then also, if you get your reports back and you just have like questions that you think maybe some of your data might be able to answer, or else if you want to know some trending that's going on within the collaborative, I love those types of requests, and just send me an email and we can get that taken care of. Along with the quarterly data reports, I'm also sending a fall rate data update worksheet. It's in Excel, and I'm sure a lot of you will remember that from the past. We will be sending that to all the hospitals in the collaborative. And we'd really like you to contribute to this, to add your fall rates to it. If you haven't been reporting, that's okay. Just send us the number of your falls and your observation hours and patient days, and you will be included in that benchmark. Once that is all put together, we hope to have that out by the end of February. So we would appreciate your participation in that. So in the last call, we kind of talked about changes to the no-fall system. We are actively working on that right now. We're going through and we're looking at what data we're collecting. We're kind of looking at what's the minimum data that we need to include. We really have the goal of streamlining this process. Know that many of you might have other systems that you might be reporting into. We want to hear from you to see what other things do you need from the system, or if you would even like to send us your current fall event report, if it's different from what we have like posted online and what is in No Falls itself. We would love to see that. And if you have any suggestions at all, please send me an email and have your voice heard. My email is listed in the slides. We'll be working on that, and we're not going to just like post it and just say, here it is, use it. We want to get your feedback on it. So we'll put a draft together and allow you to take a look at it, and then maybe make some suggestions before we go live with that. So that is all I have for housekeeping right now on fall event reporting and benchmarking. So I'm going to turn it over to Vicki, and she's going to talk to you about some ideas about engaging patients and families in fall risk reduction.
Thanks, Anne. Hi, everyone. This is Vicki. So as we were brainstorming a topic for today's call, we recognize that patient and family engagement has gotten a lot of interest, and it's a really hot topic in healthcare. So we thought that today we would talk about some ideas for how we can engage patients and families in our fall risk reduction effort. So the way we would like to structure the call is we put our heads together and brainstormed a whole variety of ideas that we thought could be feasible for implementing in your facility, or things you could think about. And then we want to open it up to you all for idea sharing. So things you've tried that have worked well, things you would like to do but haven't been able to try, things you did try and it was challenging, and what were the barriers, so we can benefit from the wisdom of the collaborative. And then Dawn will wrap up with a summary of what we can learn from the literature about patient and family perspectives about falls to round out our topic today. So we'll start with some of the ideas we came up with for how you could engage patients and families in fall risk reduction. First, we thought about ideas you could engage in at the bedside. So many of you are probably familiar with the Teach Back process and the Ask Me 3 process. So we could implement Teach Back processes after patient and family education on patient fall risk factors and the reasons why we're implementing certain interventions to keep that patient safe from falling. So this process really allows us to determine how well we as staff are explaining the information about fall risk reduction to patients and families. So the process of Teach Back includes sharing information, asking questions, listening to responses, and then sharing information again and asking as needed to make sure that we've really explained things well. So we put some example language on the slides, whether you can see them here on Zoom or we also sent them out through email. So some sample language you could use to start that Teach Back conversation. It could be something like, we discussed a lot today about preventing falls while you were in the hospital. I want to make sure I explain things clearly. What are 3 things that we will do that will help to prevent you from falling while you are here in the hospital? Other language you could say, just simply, I want to be sure I explain everything clearly. Can you please explain it back to me so I can be sure that I did? Or I want to be sure that I did a good job of teaching you today about risk for falls. Could you please tell me in your own words what you will be doing while you are here in the hospital to prevent falls? So some sample language that you could use to begin to integrate the Teach Back process with patients and families about fall risk reduction. Many of you may be familiar with the Ask Me 3 tool as well. This is an educational tool that's intended to help patients become more active members of their healthcare team. So we encourage patients to ask these questions of their providers so that they can better understand what their health conditions are and what they need to do to stay healthy. So in the context of fall risk reduction, we can encourage patients and family members to ask these questions. So what is my main problem that puts them at fall risk? What do I need to do to keep myself from falling while in the hospital? And then why is it important for me to do this? So we can tweak those traditional Ask Me 3 questions to talk about them in the context of fall risk reduction. Then we also want to create opportunities to just have an open dialogue with patients and family members about falls. So ask them questions, encourage them to ask you questions. We really want patients to understand the potential consequences of not following recommended interventions or the care plan, and help them understand why interventions are important or necessary given their own unique risk factors. So some of the questions we have listed here you could use to open a dialogue with patients might be to ask them about their fears of falling, ask them about how confident they are in moving around without falling, or even asking them how they will change their behavior in order to minimize fall risk. And Dawn will talk later about some of the rationale behind those types of questions based on what we've learned from patient and family perspectives about falls. We can also build on some other practices that you likely already engage in. So if you do bedside shift change or bedside shift report, you can ensure that you discuss things like the patient's fall risk status, interventions, any concerns that the patient may have during that bedside shift change or report. And if patients and families are present, you can use this as an opportunity to further ensure their understanding of risk, again, and what the team is going to be doing about it. In our Capture Falls scorecard, we encourage the use of a handoff tool to communicate fall risk across departments. So this might be a patient transferring to radiology for an x-ray or something like that. So consider conducting that handoff with the patient and the family member present so that they know that their fall risk information is communicated across staff. We can also communicate any patient concerns in that handoff as well. Another idea to engage patients and families is to encourage them to report any concerns that they may have, and also to report falls to staff. So any concerns patients might have about their safety, any changes in status, so if the patient suddenly feels lightheaded or feels like their medical status has changed, and any concerns or perhaps things that they need clarified about different fall risk interventions that are in place. Also, because some of our unassisted, non-injurious falls may be easy to miss, especially if alarms aren't in place and we may not necessarily know that the patient did fall. We really want to encourage patients to tell us when falls do occur so that we can make sure we have the right interventions in place. Everyone's familiar with the post-fall huddle, and our data show that approximately 40% of the post-fall huddles include the patient and or a family member in the post-fall huddle. So patients and families' perspectives can really help us to better identify or better understand the factors that contributed to the fall, and we can collectively develop a new plan of action to try to prevent another fall for that specific patient. These are particularly valuable for unassisted or unobserved falls because the patient may be the only person who knows what happened at the time of the fall. But they're also a really good opportunity to reinforce good practices in the case of an assisted non-injurious fall. So to reinforce why we use the gait belt, why we mobilize appropriately as a way to reinforce good practices to prevent falls for patients. From more of a system perspective, many of you are starting or already have in place patient and family advisory councils. So you can engage your patient and family advisory council on fall risk reduction initiatives to make sure we have that patient and family voice present and we understand and integrate their perspective in some of our decisions. You may also even consider inviting patient and family advisors to join your fall risk reduction team as a member, if that's a capacity that they're able to engage in, or perhaps even engage them a couple of times a year in some of your meetings. We may also ask your patient and family advisors to review your fall risk reduction education materials or any other documents or tools that you give out to patients so they can review those for clarity. Are they easy to read? Do we understand the information? They can provide some really valuable feedback on all of those materials. And then finally, we thought there may be ways to integrate patient and family voice or participation into your staff education on fall risk reduction. So whether this is in person or you have a video or you use some sort of handout or story or testimonial, you can have patients who experienced a fall in your facility share their experiences with staff. You could ask patients who were at high risk for falls but didn't fall in your facility to share their experiences with staff. And even have just a kind of global sharing of patient and family member feedback on the fall risk reduction program. So we can integrate their voice and perspective right away into staff education about fall risk reduction. So those are some of the ideas that we generated that you could consider, think about for engaging patients and families in fall risk reduction. Now we'd like to open it up for conversation so that we can benefit from the collective wisdom of the collaborative. So what are you currently doing to facilitate patient and family engagement for fall risk reduction? Are there things that you'd like to try but you don't know where to start? Are there things that you have tried that didn't work well? What did you learn from that? So we just want to open it up for conversation and idea sharing about how we can engage patients and family members in our fall risk reduction processes. And make sure to unmute yourself before you share with the collaborative.
So this is Dawn. I guess, are the ideas that we've shared, are they things that people have tried? We're just kind of curious about like how common of these suggestions. I mean, certainly we didn't come up with these ideas completely on our own. A lot of what we've learned has been from all of you, but you know, are there things that we've suggested here that at least are familiar to you, or things that you've tried before?
So Dawn, this is Tara at CREAT.
Tara.
Hi. So I've been looking at a multitude of tools. Sorry, that is a tongue twister. And I am looking at developing something along the lines of more of a patient and family, somewhat of more of a workbook that can be utilized while they're in the hospital, that has education on falls, why it's important, and then has a tool in there to facilitate like that teach back aspect with nursing staff, but is something that the patient actually keeps themselves, that can be utilized by the family as well, and then gives education like towards the end on how to stay safe at home and how to prevent falls when you do go home. So one thing that we plan on doing with these tools and kind of that idea is to bring it to our falls committee here at the hospital to discuss that further, then take it to our frontline nursing staff to discuss even further, then to determine if it's a tool that has an ease of the ability to implement, and then after that take a more refined tool to our patient family advisory council then to get their perspective on it from the patient utilization piece, and then go from there.
Yeah, I mean, that's
a great idea.
Those steps sound very sound. That's you know, getting input, kind of grassroots buy-in from all of the customers or the users of that tool, I think is a very prudent idea. So I think the strategy that you're considering sounds very strong. You know, you got to have somebody to come up with an initial idea at least, but then to get input from the people actually going to be, you know, using it to teach the patients, and then the recipients of it. That sounds like a very great strategy.
Absolutely.
So thanks for sharing. Does anybody else have any comments that they want to share, or other ideas? I know, we know, like Vicki said, 40% of you are incorporating people in post-fall huddles, patients or families, and so does that generally go well, or are there challenges that you've had doing that? Okay, we'll just move on. Hearing nothing, we'll just assume that things are going well. And like I said, we know that several of you are doing that. So Vicki has kind of compiled some web links there for some resources for some of the things that she shared about, with like Teach Back and Ask Me 3 and so on. So those web links there are free for you to explore at your leisure. Okay, so then to finish out the content that we wanted to share with you today, I'm going to talk a little bit about some research literature on this topic that has captured the patient voice, primarily the patient voice. The literature I looked at didn't really collect any information from families, family members per se, but is very interesting to kind of hear the patient's perspective about how people typically feel about falls. And so the bulk of the research that I found on this topic is qualitative research. And I just wanted to start about explaining what that is a little bit, because it's a little bit different from what people usually think about research. Usually people think research looks like, oh, there's numbers, statistics, there's tables and graphs, and that's not what qualitative research is about. Qualitative research is literally about having conversations with people to understand on a deeper level what they think about an issue. And so when I say narrative data, that's actually like, you know, we would record someone's words and interview them, and then analyze that for themes or common concepts that come through these conversations with multiple people. And so it's just richer information than can be captured with a number. It's a lot different than just sending someone a survey and saying, oh, how strongly do you agree with this statement? You can really get a little bit deeper at their opinions and perspectives about an issue, okay? So that's what qualitative research is. Now, a caveat I just want to caution you is that, everyone's an individual. And so the things I'm going to share on the next few slides here are the perspectives of the people in these research studies. That doesn't mean that's how your individual patient feels about this issue. So of course, everyone's an individual. The other thing about these is because of the nature of the way data is collected, you're having this back and forth conversation with people. The studies that I reviewed ruled out people with cognitive impairment because they just weren't going to be able to have a deep, rich conversation about these topics if the patient had dementia, for example. So just, I guess keep that in mind. So these are some common themes that kind of came across several of the articles that I read. The first one is like, what do patients want to know about falls? Well, if they're in your hospital and they're at fall risk, they want to know why. They want to know what you're doing about it, and they want to know what they can do about it as well. So they definitely want to be informed. They also want to hear consistent messaging from all staff. And so making sure that we're all on the same page is important. We don't want different messaging coming from the physical therapist versus the nurse. Say if there's different messaging about, can a patient get up on their own, for example. So staff needs to be on the same page between different professions, but also like night shift to day shift nursing, making sure that people are on the same page that way as well is important. Patients didn't mind repetition of information. And so, when you're in the hospital, you're not feeling well, you're overwhelmed, there's a lot going on, things have changed with your health status. It doesn't hurt to hear something more than once. And so having repetition, but then consistent repetition is something that is valued by patients. Okay. They also want to have some input on their plan of care. They don't want to just be talked down to or treated like a child or threatened, don't get up from this bed by yourself or else you're going to fall. That kind of language didn't sit well with people. They preferred to be treated like an adult and actually have a conversation, a two-way conversation about, again, why are they at risk? What can they do? What are you going to do to help keep them safe? So they wanted some ability to dialogue about that versus just be talked to about it. Patients don't want to be incontinent, and a really interesting finding in one of the papers was that people said that it was more embarrassing to them to be incontinent than to fall. So they were more willing to get up on their own when they know they shouldn't, if it meant they could potentially get to the bathroom in time. That was less of a risk that was less of a risk to them than the fear of soiling their bed or having something happen, on the floor between their bed and the bathroom. So that was a very strong driver for people. They also don't want to burden you. And I'm sure you've all heard that before. I got up on my own because you're so busy, I didn't want to bother you. Well, yes, we always want to emphasize that we are there to help and we want to help. But I think we also should think about the implicit messaging that we're sending our patients. And so, if you fly in and out of that room and you're acting all flustered and commenting on how many patients you have that day or how many things you need to do before shift change or whatever, that's going to send an implicit message that you really are too busy to help the patient. And so your nonverbal communication and the perception that you give out to the patient needs to match that message of, hey, we want you to call for help, and we want to be able to help you get out of bed if you need to get up. And then the other thing is that, or the last kind of points here are that the patient perception of their own risk is an important factor in how they feel about fall risk reduction efforts. And so people who recognize they're at risk, perhaps just because they know that about themselves or because you've had these conversations with them, they're going to be more likely to follow your recommendations and seek help. People receive information better if it's individualized to them rather than just generalities. So, we want you to call for help to get to the bathroom because you have diabetes and the feeling in your feet isn't very strong, and that's going to impact your balance. So really linking it to their situation is going to help them understand their risk. People don't understand also that why their mobility might have changed so suddenly. You know, yesterday they might have been at home walking around their home with no problem, and then all of a sudden they're in the hospital and you're telling me I can't get up by myself. And so again, having that dialogue, really articulating what their individual risk factors and what they can do about it and what you can do about it is important. You know, people have the perception that, oh, bad things happen to other people, not me. That's true of a lot of things, and falls is one of them. And then if you can somehow spin your messaging to kind of focus on a positive outcome, you know, we want to keep you safe when you're up and moving around so that you can go home as soon as possible versus always making it about the fall. I think that is oftentimes better received by patients. You know, focus on the prize, the positive outcome versus the negative outcome. So those are just very, very quickly, and I think the slides are pretty self-explanatory, but some, you know, from the patient perspective, some ideas that, you know, feelings that they had about fall risk reduction in the hospital. And those were all studies that were done with patients in the hospital who either had fallen already or they were at the very least at risk for falls. The list of actual articles is cited there on one of your slides. There are a couple that are open access and are freely available. And the rest, you would have to have a subscription to those journals, or if you reached out, we probably could share a copy with you if you specifically reached out for one if you wanted to see it. So, so that really wraps up the information that we wanted to share with you today. I guess, you know, we just want to remind you that, you know, if, you know, most of you are well on your way and have made some really great changes over the last several years to your fall risk reduction program. But if anything comes up that you feel that some consultation would be of value from any of us, our contact information is listed there. We have our next collaborative call and educational opportunity available in late April, and the date's listed there. We don't have a topic yet. We tend to think of these topics just kind of based on what we happen across in the literature or our own studies. Or things that come up with, you know, people email us and ask us about something. So if you have a topic that you want to know more about, let us know and we'll look into it and present on it. And then our website is always available to you as well. And like the fall risk reduction or the fall event report, we are in the process of considering we're looking at making some tweaks to that website too to make it a little bit more user friendly. So with that, that's all the information that we have to share with you. If you hadn't let us know that you were already on the call, you can certainly unmute and speak up now, or shoot us an email and just let us know that you were here. We do kind of keep track of, not to be punitive or anything, but we do keep track of attendance because the Office of Rural Health is interested in how far you know, we are reaching with this information. So.
Thanks, everyone. Have a great afternoon.